Okay, so if Silvia agrees, I think we can start.
Yes.
So welcome everyone, and thank you for joining this first year-end ReCONNET webinar dedicated to patients, families, and caregivers. A special thanks to our speakers, Silvia Aguilera and Marta Mosca, for their availability to run this webinar. Today, we will discuss a very interesting topic, which is pregnancy in rare and complex connective tissue diseases. And just a quick note about our speakers. We have with us Silvia Aguilera. She is the EPAG representative for antiphospholipid syndrome in year-end ReCONNET. And she is also a patient and the vice president of the Spanish Antiphospholipid Association called SAF España. And then we have Professor Marta Mosca, who is the coordinator of the year-end ReCONNET and full professor of rheumatology and chief of the rheumatology unit of the Azienda Ospedaliero Universitaria Pisana. And for more than 20 years, she has been running a pregnancy clinic for rheumatological diseases. A very few information on the webinar. The webinar will be recorded and published on the year-end ReCONNET YouTube channel and on the year-end ReCONNET website, so you will be able to see the recording after this. And if you want to be updated on the upcoming webinars, you can subscribe to our newsletter on our website. If you have any questions during the webinar, you can use either the question and answer session that you see in the black bar of Zoom, or the chat, which is near to the chat bar. Our speakers will be able to answer your questions after the presentation. And once you have watched the webinar, we will be really happy if you could participate to our webinar satisfaction survey. It will either appear after the webinar, or you can also use the link that is shown in the slide. And this will be useful for us as we can improve our webinars for the future. Thank you in advance for this. And I think these are our contacts, by the way, if you want to follow us. So if Silvia agrees, I would like now to give the floor to you, Silvia. You can start your presentation. Please go ahead. Thank you.
Great. Thank you, Diana. So I just want to talk a bit about myself. I am currently the EPAG representative for my disease, Antiphospholipid syndrome, APS. And I have been in the ERN since June 2019 when I joined the team. I was diagnosed with APS almost 10 years ago after a deep vein thrombosis, like many people with APS. And I joined the Spanish Association, SAF España, of which I became the vice president not a very long time ago. So now I wanted to introduce to you an anonymous patient story of one of our members that had APS. Let me just open the document. Okay, so this is the story of someone with primary APS and her pregnancy story. So I have primary APS that was diagnosed after a thrombotic event in 2011. In December 2017, I got pregnant after having prepared for it during several months. I was followed by my immunologist, a high-risk gynecologist, and a hematologist. However, I knew that being pregnant with APS meant that I was at a higher risk for developing complications. So I also prepared on my side to be as safe as possible. And I bought a blood pressure machine, and I took my blood pressure at home. One day, when I was 24 weeks pregnant, my BP was high, the blood pressure, that means. I thought maybe it had been the busy day I had had. I was also alone at that moment as my husband had to travel to the other side of the world. The day after, at 6 in the morning, my BP was still high. I went to the hospital where they confirmed after a urine test that I had preeclampsia. Summarizing, I was put on medication straight away, which enabled me to stay in the hospital 2 weeks in a stable condition. However, at 26 weeks, I also developed HELLP syndrome that got worse and worse until at 26 weeks and 4 days, I had to have an emergency C-section to save my life. I am here today because my son and I are alive because I was informed. I knew the risks, I was taking the right medication, I had a good follow-up, but measuring my BP and catching symptoms early was key. I hope that this webinar today will help all of you become aware of the power that comes with knowledge, and that by becoming more informed, you will be able to live a better life with your disease and have successful pregnancies. Thank you very much.
Thank you, Silvia. Thank you very much. So I think now Marta can start her presentation. So I will stop sharing the screen. Okay.
So thank you very much. And so in this webinar, I have prepared many slides and tried to cover many aspects of pregnancy in rare and complex connective tissue diseases. I hope that if you don't understand something, you will be able to write down some questions. So the idea would be to stop sometimes to see whether you want to understand something or you want to clarify something. And first of all, I would like to thank Silvia for her introduction, because she has said a very important thing, that knowing helps in understanding what's going on and helps to try to figure out in the severe situation what we can do. And this is really crucial and very important, and as we will see. So we had 3 questions from you, and these are the questions I will try to answer. Whether it's possible to have a successful pregnancy, if the disease can affect the baby, and the other side of the coin, if a pregnancy can have an effect on the disease. So the first question is very important, and is it possible to have a successful pregnancy for a patient with a rare and complex connective tissue disease? And I would like to say that the answer is yes. The majority of patients with rare and complex connective tissue diseases can have a successful pregnancy, but there are some buts. And the things we have to consider is that these are pregnancies which in the majority of cases are high-risk pregnancies. Sometimes the clinical situation may require that pregnancy is postponed and planned. So to do so, it might be needed that we discuss the case with different medical specialists. In very few cases, pregnancy is contraindicated. And another very important point to consider is that in the majority of cases, a treatment during pregnancy will be needed. So in what Silvia told us, we can see, and in her event, in her experience, we can see all these things. As she reminded us that she knew she had a high-risk pregnancy, that her clinical picture was discussed with a lot of doctors and in a very specialized setting, and she was taking treatment while pregnant. And I would like to show you what I already anticipated by showing you our experience in our pregnancy clinic in Pisa. Well, in Pisa, we have a dedicated clinic for patients who want to have a pregnancy, to follow them together with the obstetrician. And since the beginning of our activity, we've now followed more than 400 pregnancies. Here you can see pregnancies in patients with defined disease. You can see it's not just the diseases we're covering in ReCONNET, but also rheumatoid arthritis and vasculitis patients. The majority of our patients being undifferentiated connective tissue diseases, systemic lupus erythematosus, and antiphospholipid syndrome patients. So what you can see is that in the majority of cases, our patients had a pregnancy with treatment. Only 15% of our patients were not taking any treatment during pregnancy. And you can see there are many different therapies which have been continued during pregnancy: steroids, plaquenil, immunosuppressive treatments, heparin, low-dose aspirin, IVIG, and even anti-TNF treatment in patients with rheumatoid arthritis and spondyloarthropathies. Here you can see what happened during pregnancies. And you can see we had flares during pregnancy. So the disease can flare during pregnancy. And you see in our experience, 22% of patients with lupus had a flare, 33% of patients with arthritis. So you can go down and see the different diseases. And you can also see that we had severe pregnancy complication in about 12% of our pregnancies. And here, the conditions in which we had more frequently severe pregnancy complications were lupus and antiphospholipid syndrome. So by our experience, we can confirm that indeed these pregnancies are high-risk pregnancies.
I'm sorry, Marta, how many patients? Because you talk about 62 flares, but out of how many?
Out in lupus, for example, we followed more than 100 patients now. So it's about 22 patients with a flare in lupus. And this is the highest number of patients we have followed in our cohort. You see UCTD and lupus and antiphospholipid patients. Okay. And this is due mainly to the fact that these diseases have an onset at a very young age, maybe younger than other diseases. So it's more common, you know, lupus is a disease of a typically woman in childbearing age, and the same is for undifferentiated diseases. So the reason why we have these larger numbers for these diseases is the epidemiology of the disease. It doesn't mean that the others are less severe, so we are not following them in the pregnancy clinic, but just that these are rarer and we have fewer patients having the disease at the age of having a pregnancy.
Marta, I just want to remind everyone that apart from the question and answer box, there's the chat that they can use if something is not clear. I can be the voice of people on the chat. If someone has any questions, please use the chat and I will try and transmit your questions to Marta.
Yes, this is perfect. With Silvia, we discussed this a lot, and we would like it to be a talk and where I give some information, but the ideal situation will be that we have lots of questions and we can stop the discussion to give you answers. So the first point is, can rare and complex connective tissue diseases affect the baby? And can pregnancy impact on the disease? So we can see the situation on the two sides, mother's health and the baby's pregnancy, but these are strictly linked. So what I've learned in my experience in the pregnancy clinic is that if mom is fine, the baby is fine. And this is very important. The mother's health at the moment of conception is very important to start in the right way for the health of the baby. So on mother's health, what we should be aware of the risk of flares. As we've seen, we might have a disease flare. But we know that these diseases may cause organ damage. We will see about the kidney, for example, in lupus. So another thing that might happen during pregnancy is that even if the disease is not active, that might be a worsening of organ damage. There might be also other complications because many patients take steroids, for example. So there might be diabetes, hypertension, infections. And on mother's health, we might also have the impact of obstetric complications, particularly preeclampsia, or one syndrome which is called HELP syndrome. As you can see, HELP means hemolysis, elevated liver enzymes, and low platelets. As we've heard from Silvia, she had cesarean section very early during her pregnancy because of the risk on her life. So these complications might be very severe. The pregnancy complications, if you want to see on the baby side, are the risk of abortion, which is increased in many of the connective tissue diseases, but also the risk of an intrauterine death or a perinatal death. This means a baby, the baby is alive at birth, but the death occurs very shortly after birth. A growth restriction, preterm delivery, and neonatal lupus. Preterm delivery is a problem because babies are born very early and very small, so they are at high risk of complications.
I just wanted to say that I didn't say it. I didn't want to extend myself very much. My son was 33 centimeters and 660 grams. He had severe intrauterine growth restriction, and we stayed in the hospital in neonatology 4.5 months.
Yeah. So it's a long story after
yes,
that. Okay, so it's very important that we consider this aspect. Usually when I counsel for pregnancy, I discuss this a lot because it's really important that we try and we work to reduce the preterm delivery. Preterm delivery is not a good outcome, even if the baby is alive, okay? Because as you've heard, there may be lots of problems with that. Okay, so the mother's health, so your health. Because it's very important, because the mom has to be healthy when there is a child. You have to run after your child after birth. So mother's health, the risk of flares. The risk of flares, the deterioration of pre-existing organ damage, as we said, the increased risk of pregnancy complications, the other complications I was mentioning before should be included in these risks and effects on mother's health. The risk of flare is not the same for every disease, and even in the same disease is not always the same, but it is strictly associated with disease activity before conception. So I think that one very important message is that conception should be planned and should be planned in a moment of inactive disease. This is very important. This is something that has to be discussed with your physician and that you should know. Obviously, this brings together, and we are not going to discuss about that now, contraception, because we need to avoid a pregnancy in the wrong moment as far as disease activity is concerned. So let's plan pregnancy and let's conceive a baby when the disease activity is very well controlled. And this means also a time, because you faced maybe a moment when you were fine and maybe you had active disease, then you start treatment, then you're fine. But you have to be fine and inactive for 6 to 12 months prior to conception, so that we are sure that we are not covering disease activity maybe with high doses of steroids, but the disease is really very well controlled. So inactive disease for at least 6 months, the best would be 12 months. The more it is, the better it is to reduce the risk of flares of the disease. So plan the pregnancy. In systemic sclerosis, we have observed from some studies that also disease duration prior to pregnancy might be associated with an increased risk of organ involvement, progression. What's the meaning of this? That the data we have in systemic sclerosis show that in those patients who have had a pregnancy shortly after disease onset, the disease was not very well defined. And so after the pregnancy, we observed some worsening in the mother's condition. As I said, not all the disease have the same risk of flare during pregnancy. You can see in this slide that some diseases have a higher risk while others have a lower risk. So in systemic lupus, antiphospholipid syndrome, Sjogren's syndrome, systemic sclerosis, mixed connective tissue diseases, inflammatory myopathies, and vasculitis, the risk is higher, while the risk is lower in inflammatory arthritis. So in rheumatoid arthritis, in spondyloarthropathies, the risk of having a disease flare during pregnancy is lower. In any case, you might have a flare. So it is important that during pregnancy, we follow the patient, the rheumatologist and the obstetrician, so that we can understand very rapidly if something is happening, and we can change the mother's treatment. So we can take treatment during pregnancy, we can adapt treatment to the disease activity if there is a flare. So we can treat the disease activity, and this is very important. Here you can see the percentage of flares over the different diseases reported in the literature. You can see that in lupus it ranges from 23 to 80%, we had 22%, and the reason is that the majority of our pregnancies were planned pregnancies. In Sjogren's is lower, is 10%. In systemic sclerosis, it's about 14%. And in undifferentiated connective tissue diseases is around 20%, with 3% major flares. This means that few patients developed lupus in this cohort. We are referring mainly to data from our unit, in this case, during pregnancy. The other point is that if there is a damage due to the disease, this might worsen during pregnancy. And here I'm showing you what can happen to kidneys. During pregnancy, there is an overload of function on kidneys. And if the kidney is already working, with some problems, then this overload might cause a worsening of renal function, which might be persistent in some patients. This we have to know. And the risk of worsening is high if obviously the kidney disease is active at conception, or if there was a kidney insufficiency. So if you had, and this in the majority of cases refers to lupus in our diseases, obviously. If you have a kidney involvement, you shouldn't be worried of having a baby. You shouldn't be worried of having a pregnancy, but you should know that there may be problems, that the kidney function might worsen. But if you were in remission and you had been in remission for at least 6 months, if you have normal serum creatinine and your kidney is working rather well, you have a filtration rate above 60, if you have proteinuria which is not nephrotic, meaning not above 3 grams in 24 hours, and if you do not have hypertension, this is a good starting point. So you're in a good position, okay? While if you have some of these issues, it has to be discussed with your doctors because you might have problems for your kidney. The presence of proteinuria is not a contraindication to pregnancy. I'm not discussing a lot about diabetes, hypertension, risk of infection. These are risks which are increased in our diseases because of the treatment or because of the disease. Sometimes patients with kidney involvement have hypertension, so hypertension might worsen. The steroids, which we continue during pregnancy, might cause diabetes, and so this might facilitate the occurrence of diabetes during pregnancy, as well as infections. So these are things we have to consider, and these are things which we consider together with the obstetrician. So as you can see, for maternal health, there are issues which have to be discussed together with the rheumatologist, the nephrologist, sometimes the cardiologist, and the obstetrician, so that we maintain the maternal health as good as possible. So we start with the right point. So this raises the point to you that when you want to have a baby, you have to know that the first step will be to be very sure that you have a very well-controlled disease activity, you're taking your treatments, you're discussing with your doctors, you're assessing blood pressure, and all the things you have to do before you try to conceive your baby. I would like to underline one thing that I said already a few times, and is trying to conceive. because conception, we know, might be difficult. So it might take time before you are pregnant. So you have to continue over this time to control your disease activity, to take your treatment, and to discuss with your doctor the disease, okay? So don't forget to control your disease activity when you try to conceive a baby, because it might take time. I don't know if there are comments, Silvia, if you want to say something on this.
There's questions, but I think more so for the end of the talk, Marta. So
okay, great. So I can move on then.
Yes.
Okay. Okay. So let's see the other point. So what I discussed so far is that I have a disease and I want to have a baby. Is pregnancy going to harm me? Okay, because this is something the couple discusses, okay? So I want to have a baby, but I care about my health. I'm not pregnant. So if I have to harm my health, then I'm not going to have a baby. The other point is I have a disease. So having a disease has an impact on the baby. As I anticipated, obviously it might have, because maternal health and the baby's health are strictly associated during pregnancy. And so we would see this. Having a disease has an impact on pregnancy, even if the disease is not active. And this is due to different aspects of the disease. It might be due to the presence of autoantibodies. It might be due to a history of kidney involvement. So we have to consider this. There are differences among the different diseases. So I'll go back to the first slide, because as you can see here, I'm going to discuss aspects on the different diseases. I'm going to cover the effect of disease on pregnancy as referred to lupus, antiphospholipid syndrome, Sjogren's syndrome, systemic sclerosis, and undifferentiated connective tissue diseases, because on this we have more data. Okay, can you hear me? Okay, now it's better. So let's see lupus. In lupus, we know that patients with lupus face more often pregnancy loss. And in the general population, there is one pregnancy loss in 10 pregnancies, while in lupus, usually the ratio is 1 in 5. Patients with lupus have a high percentage of stillbirths. So this risk, this perinatal death, is up to 4 to 6-fold to what is seen in controls. There is an increased risk of preeclampsia, cesarean section, preterm labor and delivery, and intrauterine growth restriction with respect to the general population, 2 to 4-fold increase, and approximately 25% of all lupus pregnancies end in preterm delivery.
Marta, what does it mean that you see a higher percentage of stillbirths, like more than in controls?
It seems that in controls is a very rare event, while in patients with lupus, you have, let's say, if it's 1 in controls, it will be 6 among patients with lupus. Okay, so in our experience, in our patients, we had 4% of these patients, while you expect less than 1% in the general population. So it's increased. Okay, so this might be due to many facts, and one aspect, and one very important aspect, is preeclampsia, and is the presence of antiphospholipid antibodies, as we will see.
Okay, thank you.
Here you can see that one important aspect in lupus having an impact on the baby's health, let's say, so in the pregnancy outcome, is active disease. So if you have lupus and your disease is active, then you have an increased risk of having complications. You see 16% of perinatal deaths, so 16% of patients with lupus and active disease might have perinatal deaths versus 5% in inactive disease, as I anticipated, 4-5%. First trimester abortion is the same because this is very difficult to be evaluated. It's very sad to have a first trimester abortion, but it's an event which is less severe than the perinatal death or the preterm delivery, which is 49%. 49% of patients with lupus, with active disease, have preterm delivery, and 30% have intrauterine growth retardation. So these babies are small. If there was a story of nephritis, and please be aware, I'm not saying active nephritis, but nephritis, there is an increased risk of preterm delivery, of preeclampsia, which has a median onset at 34 weeks, which is not as severe as Silvia's, but still is early during pregnancy, which I remind you, usually the pregnancy duration, a normal pregnancy, ends between 38 and 42 weeks, okay? So usually a pregnancy is 40 weeks, plus minus 2. So starting from 38 weeks to 42 is the right term of pregnancy. So 34 is not as early as in some situation, but the baby might be small, okay? So this is if you had nephritis. So nephritis gives you an increased risk of pregnancy complication. What if?
Sorry, there's a question. Christina asks, how to know if a disease is active or not? I guess this depends on the disease?
Well, yes. I don't know if Christina wants to know about lupus. As doctors, we have many data to consider. So as far as lupus is concerned, we evaluate for lupus nephritis the urine analysis, proteinuria, serum creatinine, the complement level, the sDNA, anti-dsDNA antibodies. Obviously, in doubt of active nephritis in lupus, we usually perform a kidney biopsy, and with kidney biopsy, we can see whether there is inflammation in kidneys. Sometimes in lupus, together with serological manifestations of active disease, there is also an increase in blood pressure, there is an increase in weight. So there are a number of manifestations which we put together. Sometimes there are also other disease manifestations. So it's not only kidney, sometimes it's joint pain, it's skin manifestation. So it depends, because lupus is a very articulated disease with different manifestations. So it depends, and this is what we have to assess before saying for a patient, okay, your disease is inactive and then you can conceive the baby. So we have to put this, and this is what we usually do when we assess a patient in our clinic, when we evaluate the activity. So it's putting together how you feel, what you report, what we can see while we assess your joints or your skin, and the blood tests, and in some diseases, autoantibodies. In some vasculitides, we have autoantibodies, and again, serological manifestations and kidney biopsy. So it's a lot of things we have to consider. I don't know if you consider, I mean, it's not very specific, it's very for doctors, but I hope this was clear enough.
I hope Christina found she has APS, she said, but I think you answered the question by saying, because we are very similar to lupus with our joint pain and antibodies. So I think it answered the question. Yes, she says it did.
Okay.
But she says that in APS, it is more difficult to see if a disease is active or not.
In APS is more difficult. APS it's in large part a syndrome which is characterized by thrombosis. And so you have or you don't have thrombosis. But then you have also other manifestations. You might have thrombocytopenia, you might have kidney involvement, you might have neurological involvement. So it's not really the concept of active as inflammatory, or not completely as it is in lupus. So is a recent thrombosis, for example, is a decrease in platelets, is a recent event, a neurological event, I would say. And then if you have a thrombotic event, this will be considered as a, let's say, active disease. So something that probably would tell me, let's advise to postpone the pregnancy so that we start the treatment, we see how the patient feels with the treatment, and then we plan pregnancy after a while and we consider what to do.
Great, I think this really answers Christina's question.
And in lupus nephritis, if you have active lupus nephritis, then you have an increased risk, as you can see here, slightly increased risk of having a preterm pregnancy and fetal loss. So again, no active disease. Here you can see a report in a recent paper. This is an Italian paper where a nephrologist has collected pregnancies from many centers in Italy. And you can see in patients with lupus nephritis, which were the maternal adverse events observed and which were the fetal adverse events observed. So you can see that in this population, we had 20% of flares. We had also extrarenal flares, 8% of preeclampsia, 2.8% of patients, only 2 had HELLP syndrome, diabetes, infections, fetal loss in these patients with lupus nephritis was higher. Delivery at term, only 63% of patients and 28% of preterm delivery. So basically here you see all the complications I showed you in this population. You might say is lower than you reported, and it's true. The majority, for example, we actually had some patients, we followed some of these patients, and in our clinic, these were all planned pregnancies. So in planned pregnancies, the outcome is usually better than in unplanned pregnancies. And here you can see the fetal adverse events. So you can see preterm birth, small for gestational age, and even low birth weight, and very low birth weight. So we had in some pregnancies very, very small babies. What if I have a kidney insufficiency? And this is not just for lupus. I put this together with lupus because in lupus kidney involvement is frequent. It's about 45–50% of the patient population, but you might have a renal insufficiency for other reasons. So if I have a renal insufficiency and my disease is stable and I want to have a baby and I know that my disease and my kidney function could deteriorate, I accept this, but I want to have a baby because for me it is very important. I have to tell you that it's not really like that. And the severe kidney insufficiency might be one of the reasons why your doctor could tell you, I would not suggest you to have a pregnancy. Because with severe kidney insufficiency, you would be at high risk of deteriorating your kidney function and maybe entering into dialysis. And the risk of the probability of having a successful pregnancy is very low. Here you can see, and these are not data from lupus, these are data from patients with kidney insufficiency. In patients with severe insufficiency, 80% of pregnancies had problems. So it's very rare, but this you have to know. Sometimes it's very sad for us to say, no, probably you shouldn't have a pregnancy, but it's for the health of the mom and also for the health of the baby, because it's only 20–30% of good outcome. So the baby might have big problems. It might be a preterm birth, it might be a stillbirth, so death, it might be huge problems in development. So this reminds, if this happens, we should consider this point. It's very rare today in our diseases to have severe deterioration, but this occurs. So in these cases, there might be that pregnancy is discouraged by the physician. Neonatal lupus is not the lupus of the baby. So the baby does not have lupus. But during pregnancy, all the maternal antibodies are transferred to the fetus. And this happens for everyone. So also autoantibodies are transferred to the fetus. And usually, maternal antibodies do not harm the fetus, with the exception of anti-Rho and anti-La antibodies. These antibodies are observed in many connective tissue diseases, are more common in children, but you might have them in lupus, in systemic sclerosis, in undifferentiated connective tissue diseases, even in rheumatoid arthritis or inflammatory myopathies. So these antibodies, even if you're fine, even if you do not have active disease, everything is okay, you don't have kidney involvement, you have a very mild disease, these antibodies might determine in the fetus what we call neonatal lupus. So it's not lupus. The baby has not lupus. The baby is receiving maternal antibodies. And the manifestations of neonatal lupus are of two types. One type is less severe and is transient. So if it occurs, it will go away the moment maternal antibodies will go away. So 3-6 months after birth. And this situation is less severe and is characterized by some skin rash, might be low platelets, or a mild increase of liver enzymes. This is, you have to know, the doctors know, the pediatricians will, the rheumatologists will test the baby. But as I told you, usually it goes away. So it's, the mother is worried, the doctor's worried, but it goes away. It's really less severe. What is, on the contrary, worrying is the risk of a heart problem of the baby, which is called congenital heart block. This is observed in 1% of pregnancies. So 1 out of 100 patients with this type of antibodies will develop this congenital heart block. And what's that? Usually in our heart, we have a conduction system, which is the system bringing the order to contract, okay? So if this system is damaged, then the heart of the baby is beating very slowly, and this has an impact on the baby's development. It's a very severe situation, which is associated with the risk of death of the baby, intrauterine death. More or less 40% of the babies is irreversible. So when this has occurred, it cannot be changed. It will be forever. And if this occurs, these babies, when they are born, they need to have a pacemaker in the majority of cases. This occurs during intrauterine life and usually, more commonly, between 16 and 24 weeks of gestation. So we have to monitor the pregnancies of women with these antibodies to see if this happens and follow very strictly the pregnancy. The risk is lower after 24 weeks, but it is not zero. So we will have to monitor this until birth. Remember, is 1 out of 100. But as you can see, it's 20% after first episode. So if you have one pregnancy with this complication and then you want to have another baby, in my counseling, I would tell you, it's not 1 on 100, but it's 20%. Okay, so it's completely different. So I know that you will ask why. And what's so special in this 1 out of 100 pregnancies? We do not know. So I cannot tell you really who is at higher risk. I cannot tell to someone, no, this is not your problem, because you are not the one who's going to develop, and try to follow the 1%. We can say that it has been observed more frequently in asymptomatic patients, but in our practice, when we see these antibodies, we say to the patients the same thing. It's 1% risk. If you never had this situation, it's 20% if you had the first episode, and I will follow everyone in the same way. To follow pregnancy, if something happens, try to figure out what to do, treat the mother with steroids reaching the baby, and see how the baby is growing intrauterine, so that we can decide if we need to do something, if we need to do a cesarean section, how we can move on with this pregnancy.
Marta, you say this 1%, we don't know still why it happens, but in the rest of the cases, is a more aggressive lupus a sign that there will be more problems, or not at all?
For the anti-Rho, no. For the anti-Rho, it doesn't have any link with disease activity, with diagnosis. This is a standalone situation, so it's independent of the diagnosis. It's dependent only on the type of antibody that you have. So it's completely independent. So you have anti-Rho and anti-La, and you have this risk. So it's not an issue of lupus. So neonatal lupus is an issue of having or not having anti-Rho antibodies.
Okay.
So this is what I was telling you: newborns, pacemaker, 20% mortality, half within the first 3 months of life, 10-year survival for those who this problem in their heart, 86%, and preterm delivery. And this means that the fetus has a kind of heart insufficiency, high risk factors for mortality. Antiphospholipid syndrome. As we said before, antiphospholipid is in the mind of everyone predominantly a disease associated with thrombosis. And thrombosis is a problem outside of pregnancy and in pregnancy, because in pregnancy we might have placental thrombosis, and the placenta is the way we give oxygen and food to the fetus, so is the way the fetus is kept alive. So if we have thrombosis in the placenta, then the fetus might not receive enough food, enough oxygen to grow, to live. So this is the issue. In antiphospholipid syndrome, and the antiphospholipid antibodies are therefore big problem for pregnancy. And there are different types of antiphospholipid antibodies, which we know, different tests you might have. And one thing is that if you have more than one test positive, this is considered high risk profile.
Marta, someone asked if it is depending on the titer of antibodies on the quantity as well.
Yes, it does. It does depend on the titer of antibodies, and it does depend on the number of antibodies you have. And in fact, usually we consider high risk, medium, high titers. Low risk is low titers of antibodies. And again, maybe we can discuss this further if we want to. Sorry, if we want, then and this I just say, maybe the next webinars we could just put down some questions for each disease, so that we can enter more specifically into different diseases, which I cannot do because it will be 3-hour webinar today, but yeah, there are differences. And there are also things that we do in our clinical practice which are different, so we could discuss these things then. But yes, the titer and the number of antibodies are meaningful. The obstetric criteria for the classification of antiphospholipid syndrome are 1 or more fetal deaths after 10 weeks, 1 or more deliveries before 34 weeks associated to preeclampsia or severe placental insufficiency, and 3 or more consecutive miscarriages before 10 weeks. So you see that in this syndrome, in the criteria to say you have antiphospholipid syndrome, there are obstetric manifestations. So you can appreciate how this is important, how this syndrome is associated with pregnancy complications. So for everyone, antiphospholipid syndrome is high-risk pregnancy no matter what. The high-risk antibody profile is the title, is the lupus anticoagulant positivity, and is the 3 positive tests. Also, having had a previous thrombotic event, having had a previous pregnancy complication, and the other point is the association with other systemic autoimmune diseases. In fact, there is a primary antiphospholipid syndrome, but there is also a syndrome associated with lupus. So if you have lupus and antiphospholipid syndrome, this is a higher risk. Here you can see, for example, in our experience, so this again is our patients population, the impact of antiphospholipid antibodies and syndrome. And you can see that here, where I have yes, we have patients with the syndrome and patients without the syndrome, but with the antibodies. And you can see that if you have no antiphospholipid antibodies, you have some pregnancy outcomes. But if you have the syndrome or if you have the antibodies, the picture changes. You see, 37 weeks of duration at delivery. If you don't have antibodies, 34 if you have antiphospholipid antibody syndrome, 35 if you have antibodies. Then preeclampsia, again, 2.5%, 25%, 19%. These are small numbers because our numbers, so in this analysis, we had fewer patients. Here you can see preterm delivery, before 32 weeks, 25%, 14%, 50%, 36%. So you see the impact of these antibodies in pregnancy outcome. And consider that one thing, in our patients populations, all these patients were treated. In Sjögren, we have anti-Rho antibodies. So the risk of congenital heart block, I would say, is the most important risk factor in these pregnancies. As in Sjögren syndrome, as you saw in the first slide, the risk of flares is reduced. And apart from the congenital heart block, the incidence of obstetric complication is lower than in other diseases. Systemic sclerosis. In systemic sclerosis, there are fewer data, fewer pregnancies than in lupus and antiphospholipid syndrome. But you can see that there is a higher risk of miscarriages, of intrauterine growth restriction and preterm birth, which are usually linked, and low birth weight. Patients with systemic sclerosis are at higher risk of developing hypertension and to have cesarean delivery. Cesarean delivery is more common among patients with connective tissue diseases for many reasons, because you have obstetric complications, because you have flares of disease activity, and sometimes because doctors are nervous. And so it might be that in some settings, cesarean section is done because the threshold to do a cesarean section is reduced. It might happen. Undifferentiated connective tissue diseases are usually mild condition, milder than the diseases we have covered so far. But nonetheless, these are systemic autoimmune diseases, and obstetric complications are observed. Even though these are less frequent than in lupus or antiphospholipid antibodies syndrome. But we also have obstetric complication, and the majority of complications we have is babies small for gestational age. So, to resume what I just discussed, what is a problem for our pregnancies, for maternal health and for the baby's health? The active disease. If the disease is active, and we've seen this for lupus specifically, but also we can say it's true for inflammatory myopathies, vasculitis, Sjögren, then we have an increased risk for maternal health and for the fetus health. Lupus nephritis and kidney involvement is for sure a negative prognostic factor which we have to consider. Damage, previous strokes, thrombosis, the presence of antiphospholipid antibodies and syndrome, hypertension, and why high dose glucocorticoids? Because these are telling us that the disease activity is not very well controlled. If you're taking too many steroids, then something is not fine. It means that you're stopping your disease with steroids. Then it might say that your disease is active, and glucocorticoids bring the risk of diabetes, hypertension, and infection. What about treatment? When I was pregnant, I didn't want to take any treatment. So I wanted to be healthy, because there's always the feeling that any drug will harm the baby. So the best is to suffer and not taking anything. If you have back pain, then you keep your back pain. So this is a big mistake. Again, if the mom is fine, the baby is fine. And with chronic diseases, treatment is needed, not only to keep the disease inactive, but sometimes we need to add treatment to reduce the risk of the pregnancy. In antiphospholipid syndrome, for example, we may add low-dose aspirin and heparin in patients which are at risk. So sometimes we really start treatment to increase the chance of a good pregnancy. So it is very important to discuss this with your doctor, to discuss pregnancy with the doctor, because many drugs can be taken and do not increase the risk of problems with the baby and should be continued. So when you are prescribed with a treatment, tell to your doctor if you want to have a baby. Ask to your doctor if you can continue the treatment during pregnancy. And if you have doubts, discuss with your doctor. Do not stop treatment. You never, ever. If you have a doubt, try to solve this before. So that's why it's very important planning pregnancy. This is another very important take-home message. Discuss this. Do not be worried. And if your doctors do not ask you about pregnancy, then ask you. You ask them. You ask them and you tell them, I would like to have a baby. Can I have a baby with this treatment? Which are the risks if I continue this treatment? I would not to continue. I mean, my wish would be to have a pregnancy without treatment. Is this possible or not? So be sure that you know everything about this and that you start your pregnancy being informed so that you can be, you can take your treatment and I don't know how to say in English actually, be confident, okay? And so not having issues with this. Huh?
I have to say as well that normally doctors are very happy to discuss about pregnancy and to make also them involved in your plans. So if you have a doctor in which you trust, and I think people with, our kind of diseases, you have doctors that you see very often, they're, in my experience, very willing to share with you this part of your life, or even the planning of it. So yeah, talk to your doctor.
Yes, and never ever stop treatment. If you discover you're pregnant, and usually it happens on Friday evenings, and then you don't know how to contact your doctor. So this is terrible.
Yes.
But do not stop your treatment, okay? It's not going to change anything. 24 hours are not going to change anything. Even if you keep taking your treatment on the Sunday and the Saturday, is not going to change the story, okay? But it might be very, very harmful for you. So never, never stop. So I think that this is again what we discussed at the beginning. Sometimes you need, you have always to discuss about pregnancy. The data I showed you show you that these pregnancy are possible. I cannot show you the pictures of the babies we had in our pregnancy clinic, beautiful babies, and I cannot because of privacy and all these things, but I can tell you I have so many beautiful babies, and it's worth doing. So I think is one of the best things that I've done in our clinic is to start the pregnancy clinic, to follow pregnancy in a safer way. The pregnancy clinic is not going to change the story. It's going to put you with a good starting point. So stop the treatment you cannot continue, start a new treatment if you have to do that, check for any complication, treat very early complications. The complication you've seen will be there. So we can reduce by starting a pregnancy with inactive disease, by continuing treatment, by starting low-dose aspirin if needed, heparin if needed, but then there will be risks. So I'm not saying that if you are followed in a pregnancy clinic, the risk will be zero. I'm not saying that. But as Silvia told us, I knew everything. So I could understand very early what was going on. And we could take decisions and actions, we could act to allow us to be controlled and in the end to have a success, even though it was very difficult. So otherwise, the outcome could be even worse, okay? So that's something I always tell to our patients. I'm not saying that if you're followed in our clinic, then the risk will be zero. It's not going to be that, but we're going to follow you. We're going to see if something is needed, if we need to adapt something, so we are in the best position to follow things. Problems might be there.
If you understand what is going on and or the risks, and if it really happens to you, you are mentally prepared. And in difficult moments, if you are mentally prepared, mental health is so important in this kind of situations. And if you know what might be coming, this can help you so much, so much, so much. It can change everything. So it's really important. I agree with Marta.
So, okay. And, okay. So I think, Silvia, it's
my part.
Part.
Okay, so this is just a small summary of what Marta has been telling us. Just if you have to leave the webinar with some information, it is the next 2 slides, I think. So very important to do the pregnancy planning. You have to be ready, know the risks, know where you are with your disease and plan according to it, involving all your doctors, or normally we have a team of doctors behind, or just your main doctor that treats you. He or she will tell you when is the best moment for you. You have to trust your doctor as well. And it's very important as well to follow your treatments, especially if you want to conceive or you're planning to do it. This is vital. Yes. Do not stop taking your medicine. This is super, super important. If there will be a change, as Marta has said, this will be the doctor that will tell you when to change your medicine. This happened to me, for example, when I became pregnant. I found out and I was taking my warfarin, and I knew I had to change to heparin, but it was the 31st of December. So everything was closed, but I knew that this was not a problem and that I could wait a couple of days. So I got, everything got sorted out.
Yes, so I said Friday evening and it was 31st of December. So
it was 31st of December. It was terrible. It was a very good moment, but at the same time, it was very scary. So the take-home messages are that you are not alone. Now we have the internet, we have webinars like this, we have professionals like Marta reaching out and telling us everything we need to know. There's a huge community in all the social media. We have Facebook, we have Twitter, we have infinite ways of connecting to each other. Do it. If you have a doubt, there are associations, there's a lot of people that have gone through what you are going to go through. So reach out and ask questions. If you're going to do it on your own and you're going to Google things and you're going to read, use reliable sources. We have access nowadays to publications done by doctors that are in medical websites. You do not need to go into a forum by patients that only explain bad things or bad experiences. That is not always the real life. There's also a positive aspect to even when something goes wrong. So choose wisely your sources where you are getting your information from. As we said, plan your pregnancy with your doctor, talk to them, be open about it. They are very happy to help you with this part of your life. Discuss the treatment strategy with your doctor. As Marta said, if you're taking drugs and you have a question, ask them what will happen if you become pregnant, what will happen with this specific drug if you're worried. And do not stop any medication during pregnancy. This is super, super important so everyone can, you know, be as healthy as possible, you and your baby. So all the reference, Marta has sent a lot of references. They were at the bottom of the page on the left. We will make a list and they will be available on our website. So you can go back and, for example, if you want to read more about the lupus because you have lupus, they will be there and accessible with the links, so you can look at the references. So yeah, Marta, there's Kathleen from the Netherlands says that, just for information, in the last 3 years, last year, 3 healthy babies were born in their association and their moms are happy, and currently the scleroderma is under control. So
Great.
There's good news and healthy pregnancies and babies all over the place.
Yes. Just to tell you, there are registries now around Europe on pregnancies in rare connective tissue diseases. So there's one starting in Italy, in Germany. And so I think we will have lots of good information and data, and we are improving a lot. So it's incredible. 30 years ago, probably we wouldn't have done this webinar. So if you have questions, if you have something you would like to ask us, there is a email you can see here, webinar.reconnect@gmail.com, or you can email to ReCONNET, so the usual email. There is the survey, as Diana was telling you. This is the first webinar for patients, with patients, and so it lasted maybe a lot, I don't know, and so let us know, because this is really the first we've done, and so we need to learn, okay? But I hope that the information we have tried to convey you was useful, and thank you for your time. So you can see the website. We will put some material on what we discussed, and here you have all the communication, the Twitter, the YouTube channel, the newsletter. So if you want to have information, you can subscribe to the newsletter, and if you tweet and you follow us on Twitter, then you'll get all the information on all these webinars. So, and what we're doing and when we're publishing information. So this could be interesting, and you can be updated on what we're doing.
Great.
Okay.
So thank you so much, everyone.
Thank you, everyone, and have a nice afternoon.
Thank you. You too. Bye.
Bye-bye.
Bye.
Bye. Bye-bye.